Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Junge Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Kristina Bajema in Portland, Oregon, USA, and Professor Tor Biering-Sørensen in Copenhagen, Denmark, with whom we would like to discuss the efficacy and effectiveness of flu and respiratory syncytial virus RSV vaccines, focusing upon recently published cohort data from the US Veterans Health Administration and the randomized Danish DAN-FLU-2 and DAN-RSV trials, which are arguably the largest RCTs ever done in medicine. Dear Kristina, dear Tor, we're very honored to host the two of you this European afternoon and Pacific morning. Thanks for joining us.
Thank you for the invitation.
Tor Biering-Sørensen is professor at University of Copenhagen. He is the founding head of the Center for Translational Cardiology and Pragmatic Randomized Trials. Furthermore, he is the founding head of the Cardiovascular Non-Invasive Imaging Research Laboratory. He is the senior author of DAN-FLU-2 and DAN-RSV, which have been published in New England Journal of Medicine. Kristina Bajema is Assistant Professor of Medicine in Division of Infectious Diseases, Department of Medicine, Oregon Health and Science University in Portland, USA. She's first author of the paper Durability of RSV Vaccine Effectiveness, which was published in JAMA Internal Medicine recently. Professor Barbara Gärtner is a specialist in microbiology, virology, and infection epidemiology. She is head of the Department of Hospital Hygiene and senior physician at the Institute of Microbiology at University Hospital in Saarland. From the Marcus at Home team, Professor Gunnar Heine and I, Caroline Schneppe, welcome you today. Dear Tor, we are now looking forward to your presentation.
Thank you so much. It's a great honor to be here today with you. And I've been asked to go through the two studies which we presented and published during the ESC conference this summer, both DAN-FLU-2 and the DAN-RSV trial, and I'm actually showing exactly what I showed during the meeting. So first I'm going to present the DAN-FLU-2 trial, which has the title High Dose versus Standard Dose Influenza Vaccines and Cardiorespiratory Outcomes in Older Adults. And here are my disclosures. And for all the high-dose vaccine trials, I think the most important disclosure is that Sanofi funded the trials that we did. So both DAN-FLU-2, the GALFLU trial, and the Flu-HD study, which I'm also very briefly going to touch upon in this presentation. So first, why is it important to do these kind of trials, testing a high dose versus a standard dose flu vaccine? We already have a phase 3 trial that Sanofi executed where they found that the high-dose flu vaccine is superior to the standard dose flu vaccine, and the high-dose flu vaccine includes 4 times as much antigen than the standard dose flu vaccine. We know that it improves the immune response and it lowers the risk of laboratory confirmed influenza with close to relative risk reduction of 24%. But no trials for vaccines have been signed previously in the elderly population to assess whether a vaccine lowers the risk of hospitalization events. And that is the purpose of the DAN-FLU-2 trial, but also the DAN-RSV trial. And if you want to power a vaccine trial for hospitalization events, then you need to do them very, very, very large. And that is why it hasn't really been seen feasible. But by embedding randomization and capturing all data sources through nationwide registries, it has recently been possible to execute. And the purpose was exactly this, to assess whether in a randomized controlled trial, whether a high-dose flu vaccine significantly lowers the risk of cardiorespiratory hospitalizations and mortality in the older general population in Denmark versus a standard dose flu vaccine. And it's very important to remember that the control group, they actually got a standard dose flu vaccine, which is the currently used vaccine in my own society. So the DAN-FLU-2 trial was a pragmatic register-based open-label active controlled individually randomized trial conducted in Denmark, my country, over the 3 past flu seasons, When designing the trial, we planned to recruit close to 340,000 individuals. We had inclusion criteria that was age above 65 years and older, and then signed informed consent, and we didn't really have any exclusion criteria because that's also how it's done in usual practice. Of course, you have to not be allergic to receive a vaccine, but that's almost the only exclusion criteria that we have in usual care. There was only one trial visit for randomization and vaccination, and that was at day 0, as you can see here in this diagram. And then participants were randomized in a one-to-one fashion to either receive the high dose or the standard dose flu vaccine, and then they were followed through our nationwide registries for outcomes, but all baseline data was also obtained through our nationwide registries. This is a schematic presentation of how we actually executed our trial. Like in many other countries, we have nationwide registries where we identified all Danish citizens 65 years or above. Then this registry is actually linked to an electronic email system called e-box system. So we can identify everyone in the country with a specific phenotype. Here it was just based on the age criteria. And then we can invite everyone through an email system that is linked to the social security number, making it possible to recruit a high number of participants. They were then guided towards our homepage where they saw a video of me giving all the information needed to be able to provide an informed consent to participate in the trial. They signed an informed consent electronically and were then guided towards the vaccine clinics, which we have gathered throughout the country. The scheme here actually don't show all the vaccine clinics. We had 500 vaccine sites during the DAN-FLU-2 trial execution. And here the red dots are much fewer, but that illustrates all the vaccine clinics that are open year round in this company that we collaborate with. The only data that the participants gave when they were vaccinated was the social security number, and then, the randomization code, which vaccine they received. That was uploaded to my center here, where all my personal work, and we then forwarded to the nationwide registries, where we got all data on baseline and follow-up data. So participants were followed for clinical outcomes from 14 days following the vaccination until the 31st of May the following year. We designed DANFLU-2 with the primary outcome of being hospitalized for influenza and pneumonia. And our key secondary outcomes included hospitalization for cardiorespiratory disease, all-cause hospitalization, all-cause mortality, and hospitalization for influenza and pneumonia assessed separately. We were allowed to test these secondary outcomes in a hierarchical order due to how we designed it. And just for us cardiologists and nephrologists that are not used to understanding the relative vaccine effectiveness, which is the measure, our effect estimate measure, it's calculated as 1 minus the relative risk of the specified outcomes in the high dose group versus standard dose group. So it's a very simple calculation, and it's exactly the same as the relative risk reduction, right? Just so we also understand. During the 3 seasons of recruitment, we managed to randomize in total 332,000 or more than 332,000 that were individually randomized to either high-dose flu vaccine or standard-dose flu vaccine. And then we follow them through the registries. Here you can see the baseline characteristics of the DANFLU-2 population. As you can see, the mean age was 74 years of age. 49% were female, and 54% had at least one chronic condition defined by any of these conditions down here. Here we can see the primary outcome of the DANFLU-2 trial. We saw that hospitalization for influenza and pneumonia occurred in 1,132 participants in the high dose group and in 1,210 in the standard dose group, corresponding to a relative risk reduction, which is similar to the relative vaccine effectiveness of close to 6%, which didn't reach our predetermined definition of statistical significance. Because the primary outcome wasn't statistically significant, we weren't allowed to test any of our secondary outcomes. But as you can see here, we observed a lower incidence of hospitalizations for cardiorespiratory disease in the high dose group versus the standard dose group, corresponding to a relative vaccine effectiveness of close to 6%. Likewise, we also observed a lower incidence of hospitalization for influenza in the high dose group versus the standard dose group, corresponding to a relative vaccine effectiveness of 44%. I just want to remind you that the phase 3 trial that Sanofi did in 2014, the relative vaccine effectiveness for laboratory confirmed influenza was close to 24%. So this number of preventing hospitalizations, potentially preventing hospitalization, is much, much greater than just preventing the flu when determined in their phase 3 trial. As you can see here from the forest plot, the treatment effect was consistent across all the many pre-specified subgroups that we defined prior to initiating the trial. We didn't see any significant effect modification. The safety and adverse events were also similar between the two randomized groups. As mentioned, we initiated DAN-FLU-2 in the season 22-23. And I don't know if you saw in the flow diagram, but there we only recruited 20,000 due to some logistical issues. That's why we also implemented the DAN-FLU-2 protocol in Galicia, Spain, where we initiated a trial called GALFLU. But GALFLU was designed based on the DAN-FLU-2 protocol. It was exactly the same protocol with the prior intention to pooling with DAN-FLU-2 to enhance the statistical power, validity, and generalizability of the results. And at that point, we weren't aware that we actually were allowed to merge the two registries into one. And that's why we actually executed two trials parallelly. If we had known that we could combine the data at that point, we probably just would have opened our Galician recruitment as one site in the DAN-FLU trial. But that's why we have a third study called Fluency HD, which is actually the pre-specified pooled protocol of these two, where we individually randomized close to 5,500 individuals, so more than or close to 500,000 participants in GALFLU and DAN-FLU. Again, it was based on the DAN-FLU protocol, so the outcomes are the same. The only thing that differed is that this laboratory confirmed influenza hospitalization was upgraded as a key secondary outcome in the Fluency HD protocol, because the regulators said that this is one of the most important outcomes for cost effectiveness estimates, why we upgraded this specific outcome. Here you can see the baseline characteristics of the Fluency HD study, and as you can see, they were well balanced between the arms. We had, due to the GALFLU population being slightly younger, the age was a little bit lower, the mean age, than in DAN-FLU, but we had 48% female and 49% with at least one chronic condition. And as you can see here, our primary outcome was met in the Fluency HD study, where the high-dose flu vaccine significantly lowered the risk of being hospitalized for influenza and pneumonia, corresponding to a relative vaccine effectiveness of close to 9%. Furthermore, high dose significantly also lowered the risk of any cardiorespiratory hospitalization, corresponding to a relative vaccine effectiveness of 6%. It also lowered the risk of laboratory confirmed influenza, corresponding to a relative vaccine effectiveness of 32%. And it also lowered all-cause hospitalization. Remember, this is any kind of hospitalization, so it's quite an inclusive outcome, and it lowered all-cause hospitalizations with a relative vaccine effectiveness of more than 2%. We didn't see any difference in all-cause mortality. For Fluency HD, we saw consistent effect across all the subgroups that we pre-specified, and I'm just going to conclude for the Fluency, just for sake of time. For the Fluency HD, which was the combination of GALFLU and DAN-FLU, which was pre-specified, we saw that the high-dose flu vaccine demonstrated superior protection against hospitalization for influenza and pneumonia, cardiorespiratory hospitalization, laboratory confirmed influenza hospitalization, and all-cause hospitalization versus standard dose flu vaccine. And all of these trials were simultaneously published with the ESC, New England Journal, and in Lancet. Because I'm a cardiologist, we also pre-specified a lot of subgroup analysis to assess the specific effect of high dose versus standard dose flu vaccine on a lot of different cardiovascular outcomes: heart failure, AF, myocarditis, pericarditis, chronic kidney disease, and atherosclerotic disease. And all of these are published now. Moving on to DAN-RSV, which was using the same infrastructure, but testing the new RSV vaccine in the society. And again, I just want to underscore that DAN-RSV was funded by Pfizer, who have developed this specific vaccine. And we know that respiratory syncytial virus can cause serious illness in older adults, especially those with chronic condition. And while the most frequent complication are pulmonary, observation studies suggest that RSV may also contribute to cardiovascular morbidity and mortality. While the new RSV perfusion F vaccine has been shown to prevent RSV-related respiratory tract illness, no randomized evidence has demonstrated its effect on severe hospitalization outcome. As I also mentioned for the DAN-FLU trial, these kind of trials powered for hard outcomes hasn't been conducted before DAN-FLU and DAN-RSV. And that is due to the fact that it requires a massive sample size, which is only possible if you do it with a lot of pragmatic features, right? So the purpose of DAN-RSV was to evaluate the new RSV vaccine effectiveness compared to no RSV vaccine against RSV-related respiratory tract disease, all-cause respiratory and cardiorespiratory hospitalization now in those who are 60 years and above. The DAN-RSV was a pragmatic, register-based, open-label, individually randomized trial conducted during the last winter season. We plan to randomize 130,000. Again, very simply, inclusion criteria, age about 60, a signed informed consent, and no formal exclusion criteria. Here, the sign-up and randomization was done online, so we only had a trial visit for those who were randomized to the active arm to receive the vaccine. So those who actually were randomized to the vaccine or won the vaccine by randomization had to show up. Those in the control arm didn't need to show up. Again, all baseline data and follow-up was obtained through our nationwide registries. Again, leveraging the same system, identifying all the 1.4 million Danish citizens who are 60 years and above, were invited through the e-box system, guided towards a homepage. Again, I gave the information needed to provide an informed consent. Here, they were then randomized after they signed informed consent online to either receive the vaccine or staying at home. But the rest of the execution of the trial was done exactly like in DAN-FLU. Participants were followed for clinical outcomes from 14 days following the initially booked trial visit until May 31st, and the primary outcome was hospitalization for RSV-related respiratory tract disease. Then we had some key secondary outcomes, which were included in the hierarchical testing sequence, and additional secondary outcomes, which weren't included in the hierarchical testing sequence. Here you can see we sent out 1.4 million invites and randomized close to 131,000 individuals to either receive an RSV vaccine or to stay at home, and were just acted as controls in our trial. The mean age was close to 69 years of age. 50% were female. And here you can see the numbers or the prevalence of comorbidities in our study population. We saw that the primary outcome, hospitalization for RSV-related respiratory tract disease, occurred in 18 in the control group and 3 in our vaccine group, corresponding to a vaccine effectiveness of 80%. And now here it's important now when we talked about high dose versus standard dose, remember, in the Flunity and the DAN-FLU, GAL-FLU, it was high dose versus standard dose flu vaccine. Here it's a vaccine versus nothing, right? That's why the numbers are so different. So here we have a vaccine effectiveness of more than 83%, meaning a relative risk reduction of more than 80%, corresponding to a hazard ratio of 0.17, something like that. Here you can see all the outcomes of our trial. As you already know, the primary outcome where we saw vaccine effectiveness of more than 80%. We also saw that the RSV vaccine significantly lowered the risk of hospitalization for RSV-related lower respiratory tract disease, corresponding to a vaccine effectiveness of close to 92%. It also lowered the risk of hospitalization for any respiratory disease, corresponding to a vaccine effectiveness of 15%. We also saw a lower incidence of RSV-related hospitalization, corresponding to a vaccine effectiveness of 88%. It also lowered the risk, or we saw a low incidence of hospitalization for RSV-related cardiorespiratory hospitalization, corresponding to a vaccine effectiveness of 84%. and also a lower incidence of hospitalization for any cardiorespiratory disease corresponding to a vaccine effectiveness of close to 10%, and likewise a lower incidence of hospitalization for any respiratory tract disease corresponding to a vaccine effectiveness of close to 21%. Again, we saw consistent effect across all our pre-specified subgroups, and we didn't see any differences in safety events across our two groups. So what could we conclude from the DAN-RSV? In this large-scale and innovative phase 4 trial, the RSV vaccine reduced the incidence of RSV-related respiratory tract disease hospitalizations, RSV-related lower respiratory tract disease hospitalization, and hospitalization for any respiratory disease among 60 years of age. Moreover, the RSV vaccination was associated with a reduction in hospitalization for any cardiorespiratory disease, suggesting potential downstream cardiorespiratory benefits of RSV immunization, and the results support RSV immunization with the RSV vaccine among older adults as part of the strategy to reduce severe cardiorespiratory complications. And again, this was published simultaneously in the New England Journal, and we also did several subgroup analysis with the cardiovascular specific focus that was also published simultaneously. Thank you so much for the attention.
Thank you, Tor, for your great presentation. Before we will start with our questions and the discussion, we will hear Kristina and see the slides about her study.
Perfect, thank you. Okay, I will give a brief background on our recent publication and work, but first to start to familiarize you all with our patient population. Where I work, we provide care to former U.S. Military service men and women across the United States, and roughly that translates into about 9 million men and women who are enrolled in our care. And, while we aren't Europe, we are fortunate enough to have a very rich electronic health record database system to support this kind of research, which also integrates with some other databases, such as vaccinations that might be received outside of our healthcare system to support this type of observational research. I have no disclosures. These studies have been funded by VHA. So, by way of motivation, I think you've heard that the clinical trials in this space in terms of RSV vaccination were very promising, showed moderate to high efficacy in protecting against RSV-related disease. However, individuals at the extremes of age, particularly those who are 80 years and older, were not well represented, and immunocompromised individuals were also excluded largely from these clinical trials. And where I work, that's a lot of our patients. And so we decided to conduct essentially to emulate a target randomized controlled trial of vaccination with one of the subunit RSV products versus no vaccination between September of 2023 and March of 2024, with follow-up extending through March of 2025, so essentially covering 2 respiratory illness seasons, and evaluated protection of these vaccines over a longer period of time, over 2 seasons, against essentially medically attended RSV illness. So how did we execute this? We use a nested sequential study design with matching. So we start with each month and identify a cohort of eligible individuals as of September 1st of 2023. And during that month, individuals will either be vaccinated or not. So for each vaccinated individual, you look at the date of vaccination, say it's September 10th, and you match them to someone who remained unvaccinated at least through that same date, September 10th. And then you follow them through the end of the study. And we used a mix of exact and propensity score matching using a number of demographic, geographic, and clinical variables, including a careful look at healthcare utilization. The pool of unvaccinated individuals who was not matched in that first month study then go on to be considered as for the October trial, the November trial, and so on and so forth. And so at the end of the day, you have 7 nested sequential studies that you can pool into one. We ended up having a median follow-up of just under 16 months over those 2 respiratory illness seasons. And essentially, as was described in the previous presentation, you can calculate VE, which is essentially relative risk subtracted from 1. And we get cumulative incidence curves that we can essentially compare at the end of follow-up to get that relative risk. So a few comments first on our patient population in this study, predominantly male, given the patient population we serve, with a median age of 76 years and a high prevalence of a number of comorbidities, including 44% who had cardiovascular disease, 41% with diabetes, 31% with chronic lung disease, and immunocompromised ended up constituting about 7% of the study population. Now, infection was our primary outcome. And by that, I mean laboratory confirmed RSV diagnosis, which had to have occurred in a medical setting. This was across outpatient, emergency department, and hospital settings, but very much driven by the emergency department care that was received. And then we had several secondary outcomes, including RSV-associated emergency department or urgent care, which essentially were those events occurring within plus or minus 1 day of that positive RSV test, hospitalization defined similarly, and then ICU admission extending from an ICU care from the day before to 3 days following that positive RSV laboratory result. And what you can see is that similar to the clinical trials and what was just presented, that protection looks great initially, and then over time, that protection does decline. One important point here is what I am showing at each time point is not vaccine effectiveness at that particular month, but through that particular month. So if you look at vaccine effectiveness at 6 months, that represents protection from 0 through 6 months. We pre-specified several subgroups, including age, the product, CAN score, or care assessment needs score, which is unique to our healthcare system and essentially predicts 1-year mortality. And, there was a general decline across all of those subgroups. But I think what was most interesting was what we were seeing in our immunocompromised patient population, where we saw a marked decrease that was very different from the non-immunocompromised population, from 75% initially to 40% by the end of 18 months. These include individuals who might have received a transplant, might have been undergoing chemotherapies for malignancy, might have been on things like rituximab, HIV with reduced CD4 or any active treatment for, or any rather hematologic malignancy. And so taken together, I think these really suggest the need to think about a second dose, and particularly maybe earlier in immunocompromised individuals than others. And there is, ongoing work in other groups to evaluate this.
Thank you very much for your presentation. So, Barbara, please,
Yes.
your comments and your questions. Please start the discussion.
I have pleasure for the first questions. First of all, congratulations to both of you. These are really great studies, and it's an important information we can gain from these studies. First of all, I would like to start with you, Tor. You established a new type of study in a way with the Pragmatic randomized control trial, and you have a lot of experience now with it. You did it for influenza and for RSV vaccination. I'm sure you have some new ideas where you can use this model.
Thank you so much for the question, Barbara. Yes, definitely. So I'm a cardiologist. So I mainly do trials within cardiology, and we try to use the same infrastructure for all of our trials that we do. And we do several cardiology trials specific. They are much more cumbersome, right? Because you need to send out, tablets often in a decentralized way, and we try to do all of our trials decentralized because we can see that participants want to participate if we do trials where we don't put burden on them to participate in a trial. So that's very, very important for me and for all our trials to do it decentralized. Vaccines, of course, are unique in the fact that it's just one hit, so we don't need to send out tablets. We just need to get them in and get them one vaccine, and then we can follow them through registries. And therefore they are uniquely designed to do these pragmatic giga trials.
Yeah.
And we have actually continued recruitment in the DAN-RSV trial because we didn't really reach the numbers of events that we wanted. I don't know if you remember, but we only had 21 of the primary outcome events, and that's a very, very small number compared to randomizing 130,000.
Mm-hmm.
So that trial we actually have boosted and plan to recruit up to 700,000 this season. Also because we saw that the Danish citizens were very interested in having that vaccine. So the DAN-RSV study will be extended, and then we'll also follow our cohort to look at what Kristina mentioned here, the long-term vaccine effectiveness of this vaccine, because we followed them for free in the registries, right? So we can obtain, 1 year, 2 year, 3 year, 20 years vaccine effectiveness. But of course, we're moving into other vaccines now. We just this week or today started vaccination in DAN-COVID, testing the COVID vaccine in the 50 to 64 years old, again, powered for clinical outcomes and not just a positive test. Hopefully, we will be able to do the combined vaccines in next season, testing whether the relative vaccine effectiveness of combining vaccines are superior to giving them independently. And then we also are planning to do other vaccine trials which are powered for non-typical outcomes like dementia or MACE, cardiovascular outcomes. But yes, of course, this infrastructure we can use to test a lot of different things. Vaccines are very, very easy to test in these systems, but my professorship is in randomized controlled evidence, so I don't really care what it is I'm testing. I just want to do it in a randomized fashion, and we're doing a lot of different trials. Also, the newer medications, in cardiovascular medicine, you only need to give it half a year. So you're beginning to move into a vaccine kind of distribution of your medicine for cholesterol lowering, for hypertension with these newer targets like small interfering RNAs and so on. And there we are also in the process of designing these Pragmatic trials to test whether a hypertension vaccine might make sense to lower the risk of cardiovascular outcomes on the long run, like cholesterol lowering vaccines, cardiovascular prevention vaccine. So now the infrastructure is established, and of course, we can leverage it to test any kind of medicine that we need to test, leveraging the system. But vaccines are definitely an easy way of leveraging these systems. So you're completely right. Moving on to the next vaccines.
Yeah, it's a real milestone. When we go to the results, you had quite different results from the GAL-FLU and the DAN-FLU study. Any ideas why this is the case?
So I didn't show, we actually did a trial, the DANFLU-1 trial previously. That was our pilot. It was our first pragmatic large-scale trial testing just this infrastructure. And learning from that, we saw that the pneumonia events were lowered significantly. This was pre-COVID pandemic, and during the pandemic, a lot of things changed within usual care, right? In Denmark, we test everyone that enters a hospital who have, respiratory symptoms and infection symptoms for flu and COVID. So now we are correctly diagnosing all flu hospitalizations within the correct box. So adding the pneumonia outcome diluted the effect estimate, because influenza hospitalization is not hidden anymore in the pneumonia diagnosis, which it was pre-pandemic. However, in Galicia, 1/3 of the influenza, so 99.8% of all our influenza cases in Denmark had a positive swab, right? And we swabbed much more in Denmark than in Galicia. In Galicia, it was only 2/3 of those who had an influenza diagnosis code who had a positive flu swab, right? That didn't really exist in Denmark. You only got the influenza diagnosis code if you had a positive flu swab while you were hospitalized. Whereas in Spain, they still give a diagnosis code, a very specific diagnosis code, and say, I know the clinical presentation. And that's also why you can see that they have influenza cases hidden within the pneumonia diagnosis code. Why they had still, as we had previously in Denmark, an effect on the combined outcome, flu and pneumonia. It wasn't a high vaccine effectiveness estimate, but they have had a vaccine, a positive effect. Whereas in Denmark, when combining the pneumonia which is no longer hitting any influenza hospitalization, Danish data. We just diluted it so much that it became non-significant, the primary outcome. So designing a new trial, and we already learned that if it's within flu and COVID, we need to use the very specific outcomes, if COVID or flu. As you can see for RSV, for example, we saw an effect on all-cause respiratory hospitalization. So there you still have RSV hidden within the more general diagnosis codes. So this is based on the coding practices in the countries where we do these pragmatic trials. And it also changed. Remember, DAN-FLU was over 3 seasons, right? So we initiated the trial many years ago, whereas DAN-RSV, was only over 1 season. We've learned now that the mistake that we did for when we designed the DAN-FLU trial, designing the primary outcome with the pronomia, the less specific and the very specific outcome, that shouldn't be done for COVID and flu. There we should use the specific outcome. Whereas for RSV, for example, we could still have had a positive trial with the less specific outcome because we don't really swap in the similar fashion for RSV. So it depends on which virus you're designing your trial from. And that's also very important for us, learning this when doing these trials, embedding it in usual practice where you are dependent on what is going on in usual practice. And for us, it's really dependent on the testing practices for these specific viruses, right?
Okay, that's clear. So probably for the future, you have to adapt the protocols. Depending on the diagnostic coverage.
Exactly, adapted to which kind of viral pathogen that you're looking for, and basing it on the testing practices. And then it's hard to design a trial, when you have pre-pandemic numbers, to use that now because the testing practices has, changed completely now.
Yeah, absolutely. So, Kristina, thanks a lot for your excellent talk. I have a few questions to your study. First of all, were you disappointed when you saw the numbers?
I think I expected them, right? I was, the previous iteration, we looked just at the first season and we said, fantastic, this is on par with what others are seeing in clinical trials. And we're even still seeing protection amongst 80 and older and immunocompromised, some more vulnerable patient populations. So that was reassuring. And just, given my experience in infectious diseases with all vaccines, there are very few that it's one in a lifetime and you're protected for the rest of your life, right? So that's to be expected, particularly for respiratory illness that you have to think about revaccination. That's a daunting thought, though. In particular for RSV, we've seen some early clinical trial data that 1 year interval wasn't perhaps appropriate, or maybe it was too early. So is it 2 years? Is it 3? Is it 4? I don't know. And I think we need more work in this space.
Okay. We have not only the one vaccine you tested, but we have an adjuvanted vaccine and an mRNA vaccine as well. Do you expect different results in using the other vaccines?
So in our healthcare system at the time of the study, we had very little, if not negligible, mRNA vaccine use. So we couldn't say anything about that. We had the 2 protein vaccines. Now we did pre-specify subgroup analyses of one and the other, and they looked largely similar in terms of performance over time. Again, this was not a head-to-head comparative effectiveness study, and I think that can be done in the future once we accrue enough numbers. It's a little bit tricky, though, because you have to think about why facilities or individuals are getting one or the other. In an observational study, that's not randomized. And so we have to be careful about, well, were there certain facilities that were preferentially giving the adjuvanted versus the other because of some preconceived ideas about maybe reactogenicity or what might be superior. And so technically and analytically, that becomes more challenging to evaluate.
So we have a lot of immunosuppressed patients here, and probably an adjuvanted vaccine might have some advantages. Do you think that?
I think that's a lot of individuals, practitioners share your perspective on that. I would love to see, the studies to kind of formalize that hypothesis.
So thanks. So Caroline?
Thank you. Yeah, I also have some questions and maybe also some health publicity questions. First, a question to DAN-RSV. The study confirmed that the vaccine is effective but we see the small number of cases is a little bit surprising. And you mentioned in the study that maybe the insufficient testing is maybe a possible limitation and a problem why there are so less number of cases. But however, when we see the both groups, the total hospitalizations and the death from any cause didn't differ significantly. So from a public health perspective, and considering the cost pressures facing in healthcare systems, is this vaccination profitable?
That's a great question, Caroline. We have already pre-specified a cost effectiveness analysis, taking all of this into account. We haven't executed yet. We just, as you know, we just published this trial, a couple of months ago. So we haven't been able to execute that specific analysis. But I think it's important. I agree completely. We expected to have close to 80 events, with the testing strategies assessed the previous season. That's how we came up with the 130,000 randomized. That was based on 80 primary endpoints, RSV-related respiratory tract infection. We only had 21, so we had 1/4 of that. And just from the previous season, which we used to assess the event rate, the testing practices for RSV got reduced. So, from using multiplex testing system in most hospitals, they apparently went into just using testing systems which only tested for flu and COVID. So that's, of course, again, you are under the big umbrella of what is happening when you execute trials within the real world setting, leveraging data sources from the real world sources. So testing for RSV went down from the previous season to the season where we conducted DAN-RSV. That's also why we're boosting the recruitment for this season, because we still want to reach our 80 events, and then we're also expanding the age category that can participate in the trial. However, one important thing to note is the fact that we saw a significant lower incidence of all-cause respiratory hospitalizations, right? So we know that it potentially prevents many more hospitalizations and they're just not diagnosed. And this is exactly underscored that if you just take all hospitalization events with any kind of diagnosis code, and this is COPD, asthma, whatever, then you do see a 15%, I believe it was 15%, now I can't remember the exact numbers. We've gone through so many presented numbers. I believe it was 15% that you lower a relative risk reduction of all-cause respiratory hospitalization with a substantial amount, right? So we believe that it could potentially be cost effective, but that specific analysis needs to be done. And currently the RSV vaccine in Denmark is the most expensive of all the adult vaccines, right? So it also have to be very effective of lowering these events. I believe the all-cause hospitalization, the actual estimate was quite close to what we saw in DAN-RSV, but again, it wasn't, we only randomized 130,000 versus 330,000, right? So I think we just need to wait, and that's also the unique thing as Kristina took us through. This is a vaccine that is effective for several years potentially, right? So we will just keep on capturing the potential events that this vaccine has prevented in this system. So next summer we are going to read out and report the 2-year results of DAN-RSV, where we have captured many more events, having higher statistical power with more precision of the potential events that we capture, of course, with a lower vaccine effectiveness, as Kristina showed us, But all of these questions we haven't assessed yet, but this will be determined, and the specifically cost effectiveness analysis is pre-planned and already designed with a protocol specifically for that to assess does the 2,000 kroner per vaccine, is that cost effective for how many hospitalizations that we potentially prevent, right? So great question.
Thank you. And I have also a question. Is the question I often ask our guests because I'm really interested in it. We see in DAN-FLU patients with immunosuppression appear to benefit most from the high dosage vaccine. And what was the exact definition of immunosuppression? So is it a low dose cortisone dosage, for example? So what was the exact definition from the immunosuppression? When do you say, okay, this patient have a immunosuppression and this patient don't have an immunosuppression? Is it like a chemotherapy, or is a CKD patient, for example, also, we know there are some differences in the immune system. So what was the definition in this study for immunosuppression?
That's a great question, and it's been something that we actually have used a lot of time designing, because it's a very broad group. It's people receiving transplant, it's chemotherapy. A big portion of them have hematological diseases. So it's a very broad group, and that analysis is, as we also discussed earlier with Kristina's presentation, is a very, very important question that we're going through now. We have done the analysis. We are in the process of submitting that paper specifically, but it's a very, very broad group of very different patients that are immunosuppressed due to different regions. The only thing that we haven't included in that definition, just purely because we don't have that data yet in DAN-FLU, is exactly whether it's just low doses of steroids, for example. We only have medication that they receive in the hospital, chemotherapy, other more advanced immunosuppressant drugs, and then the diagnosis code and procedure codes. We don't have the prescriptions that they're being prescribed if it's not during the hospital in the current version of the DAN-FLU-2 trial. So it's at least immunosuppression that is so severe that it's being treated, at a hospital and not only by GPs.
I have two final questions on DAN-FLU, and then one final question to all of you, actually. So on DAN-FLU, I would be eager to learn, firstly, since you merged your data with a Spanish study, I learned from your papers that in Denmark, the default strategy is to give the normal vaccine to everybody. So you do not recommend people above 60, like we do in Germany, to receive the high-dose vaccines. Is this same in Spain? And then the second question to DAN-FLU would be, since you randomized the people over 3 seasons, there might be some patients, or people actually, they're not all patients, that receive vaccine A in the first year, and then in the second year, and then the third year they are randomized to vaccine B. So how can you exclude that there's some kind of overlapping reaction or continued effect from the vaccination in the first 2 years?
Great question, Gunnar. For the first question, it's in Denmark, we actually had the high-dose flu vaccine, I think, for 2 seasons a couple of years back when we did the DAN-FLU-1 trial, our pilot trial, our feasibility study. That was provided for the 82 years of age and plus, and that's just purely by how many that the Danish state purchased, and then they saw, okay, we have that many of this age category, we're going to give it to the most elderly. But then we haven't had it since. So in Denmark, usual care has been the standard dose throughout the execution of this study, except for the last season. That was the adjuvant vaccine for 70 plus. But there, the data is even less. We don't have a randomized controlled trial showing that it actually prevents laboratory confirmed influenza. We will have immunogenicity studies and observational data, right? So they don't even have a phase 3 outcome trial yet. they're conducting it, as far as understood, in Romania or something like that. So there the uncertainty was that big that they said, we can't really say that it's better than the standard dose. So standard dose is usually care. In Spain, they provided the high dose flu vaccine to 80 plus. That's why the age category also, when combining, got slightly younger, because their mean age was lower. So they already have implemented the high dose flu vaccine to the 80 plus year old. For your specific question about this, about getting high dose, standard dose, and is there a potential incremental benefit of getting high dose all 3 seasons? We saw that 200,000, approximately 200,000 participants participated in more than one of our season of the 330 participants. So you're right that we do have data on some of these. Remember, the outcomes were only assessed from when they were vaccinated until 31st of May, the following sequence. So they are counted as unique individuals in the analysis. We also pre-specified in our statistical analysis plan to take into account this potential correlation, because it's the same individuals for some of them that participate, that did no difference. We have done that and published that both in the New England Journal and in the Lancet paper and all the subsequent. It doesn't change anything at all. And it was also because of the previous experience from flu vaccine trials where they did this, that we also argued that must be, a right way of doing it, because they had already tested that in vaccine trials, flu vaccine trials previously. So it didn't really change anything, but we are looking into this potential incremental effect and have pre-specified it in our statistical analysis plan, that we want to do a specific analysis to assess what is the potential incremental benefit of getting high dose every season versus 2 seasons versus 1 season versus no season, right? So you're right, that is going to be a research question that we're going to assess, but at least, statistically taking care of the interperson correlation of the persons that are participating in more season didn't really affect our effect estimates.
Thanks. And my last question actually to the 3 of you. So what do we recommend now to our patients above 60? And Caroline and me come from nephrology, so we have these people with a couple of comorbidities. Positive, you would say they should go for a high dose flu vaccine each year, but when they ask us about RSV vaccination, and from time to time they ask us, is it just one vaccination or should there be a second vaccination in the not too far future? Surely we cannot answer this for sure, but what would you suggest us to reply to our patients?
I hope to give that question to the 2 of the participants, but I can also comment on that if you want at a later stage.
I think despite evidence that these vaccines work, the real problem that we have is we're still under vaccinating, right? Individuals who have an indication. And so I go back to just get whatever you can, because that's better than nothing. And for now, I'm not sweating the details in the clinical practice in terms of which is better. Obviously, we do think a lot more on the research space about what might be better. And I'll just say for flu in the US, our recommendations above 65 are to give either high dose, recombinant, or adjuvanted, preferentially over standard dose, but there is no recommendation as to which is better. So for us, the clinical question of interest is, well, okay, is it high dose or is it adjuvanted? And that would be, a really interesting study to see.
So I would absolutely agree with that. It's best to be vaccinated for an immunosuppressed person, but I'm really interested to see the data about the absolute number of infections of RSV that we can really protect from using the vaccine. And I'm really not so sure about the number of hospitalizations. You are the experts for that, but even in the studies for the initial 3 vaccines, there was a very low number of hospitalizations in that studies. So I'm not so sure about the the clinical impact of RSV, it's for sure different to the one of influenza. It's clearly a lower number, I would guess.
And I can also just comment on I agree with both, and I think specifically for the RSV, I also think a big problem is the fact that we don't really diagnose that disease in a similar fashion as we do for COVID and flu. And I think just the observations that we saw with the vaccine effectiveness of 15% on all long diagnosis code shows that we don't really diagnose this disease in a similar fashion, right? So I don't really think we have a true idea of the magnitude of what this virus actually have yet. We have that in a much greater sense for COVID and flu, but less so for RSV. So yeah.
So, dear Kristina, dear Tor, and also Barbara, thank you so much for your participation. It's fantastic to be able to discuss such large studies with real-world data here. We are sure that there will be other topics and papers in the future that we'd like to discuss with you. So we are looking forward to seeing you again in the future. Thank you so much. And yeah, thank you, and we'll see you again, I hope.
Thank you very much.
Thank you.